Thank you very much. It's a delight to be with you. I have to tell you, I'm sitting here thinking in some sense this is like carrying coals to Newcastle. I know your reputation. Derek Feely shares it with me routinely. I've had some of your patient safety fellows. I'm deeply impressed. I came to learn, and I think I have learned a very great deal about good approaches to healthcare. I hope that what I share will provide some utility to you as well. I regard you as a leading system in the world. Doesn't mean that we can't be better, though, does it? And in fact, that's what the times demand of us, that we improve our care. The evidence is overwhelming that care delivery today in the free world, but more than that, systems like ours, is literally the best the world has ever seen. That's a very easy case to make on the evidence. But I regard it as the duty of every generation of the healing professions to pass along something better than we ourselves received. So let's think of it in that context a bit. They asked me to address the topic of quality and cost, and thinking upon it, I thought that maybe the best way to do that was to share my own personal experience. I have to understand, I'm a little bit older than most in this room. I was in my medical training in the mid-1970s, and I remember some telling experiences. As house staff on a surgical service, I had the temerity to question. We had a chronic alcoholic who came through our service with some regularity. He had been picked up by the police, inebriated. He was comatose, and he was in our ICU. And it was pretty clear in our initial evaluation that he was not long for this world. And I remember on rounds with an attending physician suggesting that it may be inappropriate to place him in an intensive care unit, occupying that bed and consuming those resources. I was severely chastised for even raising the question of resources relative to a human life. That was the norm of the day. You couldn't talk about cost in the context of a human life. And the belief was that quality meant higher cost. Quality meant pull out all the stops. Quality meant spare no expense. If you see that idea. That's how I was clinically trained. And through those sorts of experiences, it was pounded into our very souls in some depth. I learned not to ask that kind of a question again. Just get on with the care and find an administrator to abuse if he raised the issue of cost. I mean, it gave me a set of tools. Why not? It changed for me when I returned from Harvard School of Public Health and Dana-Farber Cancer Institute back to Utah. We had done a series of studies looking at variation in care delivery and found dramatic variation, very carefully balanced patients. We were the first group that drove the variation data down to the level of individual patients with similar diseases receiving care in the same facility. We'd analyzed it along the lines of physicians, and we could show these real differences from one physician to another in the same facility. It was troubling. It was hard to even understand that the differences could be so large. It clearly wasn't the patients. We'd controlled for that. Well, in that context, a colleague, a fellow named Paul Batalden, pediatrician from Minneapolis, he's been a real leader in quality improvement. He looked at our studies and he introduced me to a man named W. Edwards Deming, the father of quality improvement theory. I first met Dr. Deming at the Hotel del Coronado in San Diego in December 1987. He held a 4-day course, and I signed up and attended his course. Now, at the time, I thought I was the only physician in the room. It was a whole bunch of engineers. Turns out later I discovered that Maureen Bisignano, who's now the CEO of the Institute for Healthcare Improvement, was in the same group. I just didn't meet her. It was a large group. But Deming made the strangest argument. He argued that as you improve your quality of care, in most circumstances, it should cause your cost of operations to fall. He was arguing that higher quality costs less. I don't know if I can describe how antithetical to accepted medical belief that was at that time. This was the idea that the sun circles the earth, pretty much. The trouble was he had a plausible argument. He talked about the mechanisms by which it worked, and they made sense. What I did was go home to Salt Lake from that trip Well, I had a colleague, Dr. John Burke, was the head of infectious disease at our then flagship LDS hospital. And John had a trial underway. Now, John Burke is the man who published the initial data on timing of prophylactic antibiotics to prevent surgically associated wound infections. And kicked off, in some sense, the whole patient safety effort. That happened at LDS Hospital. The article was published in January of 1992 in New England Journal of Medicine, lead article. Well, I go home. I'd been helping John with his trial a bit. And this trial's just getting underway. And I say, John, this guy Deming, he has this crazy idea about cost and quality. Have you ever thought about tracking a cost outcome as part of a trial? Now, there's an idea. I said, you know, it appears that it's just another number. And we're clinical researchers. We're really good at that. What if we just tossed in another number into the trial and see what it shows us as we go along? And John allowed us how that might be pretty interesting. It sounded like fun. He challenged me. He said, well, where are we going to get the cost data? Well, when I'd come to Intermountain, I'd met a fellow named Steve Busboom. He was their vice president for finance over on the administrative side. He had built one of the world's first activity-based costing systems. And I'd become somewhat familiar with it. I knew how it worked. It meant that we had accurate cost data on every case we treated. So through Busboom, I could measure cost. So I had the data. And that's what we did. We just stuck it into the trial. Now, this is something called a conceptual flow diagram. It's the one we actually used to lay out the trial. So 5 major sources of potential infection in a hospital. They chose to focus on deep post-op wound. 3-step process for that. They chose to focus on prevention. Now, a conceptual flow diagram, every box hides another flow chart. And it's a way of dealing with complexity in a clinical process so that you maintain context and then are able to focus in. So, for example, patient preparation. When I was practicing surgery, I knew that I needed to get bacteria off the patient's skin before I took him to an elective surgical case. So I would ask them to take a Physohex shower twice the day before surgery. I could have done as well with ivory soap, by the way, but we used Physohex. It's a little more expensive, but hey, who's paying attention to cost here? I know that I need to remove hair from the surgical area. Bacteria can move into the surface of hair and be protected from antisepsis. The antiseptics you use at the time of surgery. In removing that hair, I would really prefer to clip than to shape. I don't know if you've ever seen a photomicrograph of the surface of the epidermis after you run a razor blade across it. It denudes the skin and you get these little microscopic skin flaps. There's pretty strong evidence that bacteria can move into the surface of shaved skin and be protected from antisepsis. It's directly associated with higher infection rates, at least superficial, that we believe lead to higher deep infection rates. See what I'm getting at? Well, wait a minute. I'd rather clip than shave unless I shave at least 24 hours in advance. In which case, the epidermis will reseal, the risk disappears before the hair can grow back. See the idea? Now, the point I'm trying to make, see all the detail that box is hiding? And that's its whole point. Well, they chose to focus on prophylactic antibiotics. Here's the subflow around prophylaxis. Now, at that point, I'm coming down to the level of what we call decision layer, where these things morph into, turn into evidence-based best practice guidelines. And they chose to focus on timing of delivery. So we ran the trial. Here's a short summary of the results. In 1985, we were giving prophylaxis to patients correctly 40% of the time. In 1986, it was up to 58, as John and his team introduced process mechanisms, we would call them today, to help us with timing of prophylaxis. We actually tried 4 or 5, but by 1991, we were up to about 96% on time. No change in choice of antibiotics, no change in patient selection. So this isolated, just timing. Infection rates using a research quality tracking system. So you have to track patients after hospital discharge to pick these up properly. We were at 1.8%. Now, just to put that in context, there was a national standard in the United States at that point in time. It was the Joint Commission Scoring Guidelines, who came past to do oversight review from an outside agency. They said in their scoring guidelines that a good program would have a infection rate. This infection rate should be between 2 and 4%. So we were just a little bit better than the best national standard. when we started. There's a message in that. How do you pick where you'd start? You want to hear the funny thing? This is one example. Most of the areas where we've shown major improvements in clinical outcomes, when we started, we were better than most places in the United States. We were already a leading institution. That's a crazy statement. It's what Jim Reinertson called being cream of the crap. And what you learn across time is that comparisons to peers to pick targets is not the most effective way to pick improvement targets. Repeatedly, we would be outperforming almost all of our peers and get major advantages. What you look at instead is something that John Williamson from Johns Hopkins called achievable benefit not achieved, between the science that you could apply that you believe could reasonably work in your current performance. How big is that gap? And that's how you set this up for choosing targets. Well, anyway, yeah, by 1986, the rate had dropped to 0.9%. By 1991 to 0.4%. We established a new standard for infection control. Well, yeah, we threw in the cost data. The way I'm showing it here, we used Busboom's system and estimated when we got one of these infections on average in $86. It cost us $14,000 per case to treat the infection. It's additional hospital time, sometimes some follow-up surgeries, wound debridement and the like. It's dressings, drains, antibiotics. Well, that translates to, in 1986, $462,000 that the hospital did not have to spend on infection treatment. By 1991, it had increased to $714,000 per year. And we walked away convinced that Deming had it right. Now, you want to hear the really funny thing? When we first submitted that article in the New England Journal about time of prophylaxis, that old seminal article, we put in the cost data, and New England Journal forced us to take it out. They said that it was inappropriate to put in a clinical article, which was the norm of the day. So we dropped it and published it, and we didn't forget it internally. In fact, a few years later, I threw in some extra figures here, didn't I? Percent elective surgeries receiving prophylaxis about stable. Percent receiving first dose 0 to 2 hours before incision, 40 up by 94 at 99.1. Percent continuing prophylaxis 24 hours after surgery. By the way, prophylaxis is not clinically efficacious after the surgical incision is closed. In most cases, there are some exceptions, but in most cases, this should be closer to 0. That was way too high. Mean number of doses coming down. We deployed it system-wide and watched our infection rate across the entire Intermountain system then drop. Dr. Greg Schweitzer actually did this particular study. So organ space and deep infections per 1,000 cases, appropriate cases treated, where this would apply. This drop from initially about 1% down to 0.5% for the system, that was about $3.5 million per year at the time for the Intermountain system. LDS is just one hospital. So significant cost savings. Now, there's some theory that lies behind this. This was the actual study where we had a glimmer that there might be a different way of thinking about cost in healthcare. And so we started to take Deming's ideas and try them in lots of other areas because this looked fairly attractive, frankly. Yeah, Deming's theory looks like this. So this was his argument. So Deming's first premise was that all value-adding human activity can be described as processes. It's a real simple definition. A process is just a series of steps designed to cause some outcome to occur. But that was his first premise. He argued that you should organize literally everything in a quality organization around what he called value-added frontline work processes, where value added is defined by your customers. You see? He said the way that you really serve a customer, in our case that would be a patient, is through a process that produces a product or a service. So it's that product or service. Perhaps that's a clinical treatment. He said the way you produce it is with the process. So you should organize literally everything. Your management structures, your data systems, your finances. around value-added frontline work process down at the front line. And that was his whole argument. He pointed out that every process, this was premise number 2, consistently produces 3 classes of outcomes. The first he called a physical outcome coming out of manufacturing. It's the service or product the process is designed to create. Of course, in our line of business, medicine, we would call it a clinical outcome, wouldn't we? So that was his generic word for a clinical outcome. Usually the word quality refers to the attributes of a physical outcome. That's the most common way in which we use it. Deming had the most unique way, though, of thinking about cost. He argued that it was another outcome of a process, not a budget, not an input. It was an output. He said, when you operate this process, it will have a cost associated with it. Measure it and track it as if it were an output. A brilliant move, frankly. Worked wonderfully well. And finally, we have this thing called service outcomes. Technically, it describes the interaction between the provider of service and the consumer, a patient in our circumstance, as this transaction takes place. Fair enough? Now, here was his point. Anytime you introduce change, change is always introduced down here at a process level. You see? So I introduce a change in process, perhaps to get a better clinical outcome. But he says because they all derive from the process, it will always change the other 2 as well. It's unavoidable, he argued. I make a change with the aim of a better physical outcome, it is going to change my costs, whether I like it or not. The change could be large, the change could be small, trivially small sometimes. It could be in a positive direction, it could be in a negative direction, but it will happen. In administration, I make a change to try to drop my cost of operations. That is going to change my clinical outcomes, unavoidably, every time. Could be good, could be bad, could be large, could be small, but it will happen. Now, he went on to explore a bigger part of his intellectual contribution to the science of this area had to do with the interactions between physical and cost outcomes. He left service off to the side. Technically, they have similar interactions. They're much more subtle. And because of the way that patients react or humans react, they're not as strongly associated. This one is not as strongly tied in as the other 2. It's there, it's real, but much more subtle. He focused on physical outcomes and cost outcomes. He eventually defined 3 causal linkages. He proved them at the level of mathematics, of a mathematical proof, technically, by which your quality, your physical outcomes, interact with your cost outcomes. Now, the jargon that emerged for that is quality controls cost, is a jargon that emerged. And out of it came statements like, do it right the first time, or move upstream, was some of the jargon that emerged out of that. But I wanted to show you the mechanisms by which they work. The first he named quality waste, and here's the theory behind it. He says, imagine that you have a process that's producing some sort of an outcome while a step in your process fails. You have a process failure. Not every time, but at a proportional rate, a proportion of the time, the process step failure will create or cause an outcome failure. Fair enough? So I have a process that involves prophylactic antibiotics with the aim to prevent deep postoperative wound infections. Occasionally I get the timing wrong, and I know that that's statistically associated with a higher infection rate, about a 5-fold higher infection rate, in fact. Now, not every case is going to get an infection, but the rate comes up. See the idea? Well, he says, what do you do with the failures? He pointed out, now this was in a manufacturing environment, you had only 2 choices. Number 1, you could fix the failure. You could let the process fail, inspect and come in after the fact, identify the failures, and then fix them. See the idea? Or alternatively, I could throw it away. I remember seeing an example, this time working with him. He hauled out a throwaway journal from the manufacturing industry. It was for spark plugs for a car. And they'd run this big full-page ad in like Time magazine. And they said that as they manufactured spark plugs, it was the company AC, that they individually inspected every spark plug, and if it passed quality specs, they packaged it up, sent it out, sold it to people like you and me. If it failed quality specs, it went on this pile, and they had this picture of this giant pile of spark plugs. And Dr. Deming shows this to me and says, well, what do you think? And I said, well, if I buy an AC spark plug, it means that by definition I get a high-quality spark plug, because they've individually inspected every case and tossed the bad ones, right? With that inspection regimen. It was a setup, of course. The old guy taking advantage of the young guy. He says, who pays for the spark plugs in the pile? That's an interesting question. If you think upon it a bit, it costs exactly as much to build a bad spark plug as a good one. Same amount of material, same amount of processing, same amount of inspection. Who pays for the spark plug in the pile? Well, I do. That company has to build the cost of the bad spark plugs in with the cost of the good ones when they sell me a product to be financially viable, don't they? See that idea? Well, that mechanism, Deming's name for it was quality waste. And that's actually a technical definition of a particular phenomenon. So quality waste means a process failure that produces an outcome failure, and you're forced to either repair it before it ever leaves the shop, or you're forced to redo it completely. So this is do it right the first time. Now, very often in a work environment, this shows up as work hassle. And it'll be very frustrating to those who work with it, because you'll be back redoing things, if you see that idea. So I found a classic example. I mentioned it earlier this afternoon. Liz Hammond ran surgical pathology at LDS Hospital. She came through our course doing a project. So I asked Liz, what's the biggest hassle in your practice of surgical pathology? She said, it's phone calls from physicians. She said, my department produces a surgical path report. It goes out for use. And then I'm working away trying to do my assigned tasks, and I get a phone call from, well, she was looking at breast cancer, from one of the oncologists, surgical oncologists, medical oncologists, radiation oncologists, and they want to ask me questions about the path report. She says, I have to track down the slides, I have to track down the initial report, I have to load them up in my microscope. By that point, I have to track down the physician. And then I sit and talk to them as I look at the slides. Yeah, she says it takes as long as a half hour. She built a little system to track how often this happened. About 80% of all path reports produced at the hospital was producing at least one phone call back to the department. And she realized that the reason that people were calling was because the initial path report had failed. In typifying the reason for failure, it turns out that 80% of them were missing at least one critical element in the initial report the oncologists thought were essential for patient care. I lived this when I was practicing surgical oncology. It happened all the time. You know, Liz described the surgical pathologists as, how to say it, frustrated English majors who were trying to write the great American novel, one path report at a time. That was Liz's typification of her own profession now. I'm just quoting Liz, don't blame me. What she did was generate something called synoptic elements. She sat down with her primary customers, the oncologists, and said, okay, what do you need in a breast cancer report? They came up with a list of 15 items. She and her colleagues, she twisted some arms to get them to standardize their approach. She just posted it up where they dictated path reports and said, all right, for your main path report, play fill in the blank. It was associated with call rates coming back to the department falling to almost zero. The oncologists loved it. As you might imagine, it's not that they didn't enjoy talking to Liz. She's a delightful person. It's just that they wanted to be able to move on with their patient care without this interruption of calling pathology to get information that they thought should have been there from the first. It also allowed us to computerize the whole thing. It gave us enough structure to the record to go to a very sophisticated computerized system with it. You see the idea, though? Classic quality waste. And then we started to look for it, and it was everywhere. When you had the eyes to see, this stuff was happening all over our hospitals, all over our clinics. And it was frustrating. It was rework. It was hassle. It was time that we didn't spend with our patients. I don't know. Does that ever happen to you when you practice clinically? Yeah, when you come to recognize this, it becomes a marker for improvement. How could I make it so that process works right the first time so that I don't have to go into recovery mode? Because recovery mode always takes time and wastes resources. So that's method number one that Deming described. Method number two, he called inefficiency waste. Has a little bit different theory. To really understand it, it's highly theoretic. I have to imagine that I have two processes side by side. They take identical inputs and they produce identical physical outputs. Fair enough? One of them consumes more resources to affect that transformation, to produce that product. Which one should you use? Total no-brainer, isn't it? You ought to use the one that's more efficient. The world expert on this topic was a fellow named Harry Roberts at the University of Chicago. He argued that inefficiency waste was a much larger category than quality waste. It's harder to work on, though. You don't know you have it until you find the new process that takes it out, interestingly enough. A couple of examples from Intermountain. We did those QUE studies. We had the same inputs. We carefully controlled that. We had the same outputs, dramatic differences in resource consumption. And they were great examples of inefficiency waste. Here are the actual costs for doing a transurethral prostatectomy. Carefully controlled, same patients in, same patients out, a twofold difference in cost. Now, I always think of this as a theory slide. Given the structure of the study, we just didn't have enough patients. We only had about 700 patients in this one. I couldn't tell if he was underutilizing or he was overutilizing. It's possible, has to do with statistical power, that he was underutilizing. It wasn't until after the care changed dramatically that I realized that he was mostly right. In the face of those data, in a process-focused environment, I watched surgeons change their practice and deliver dramatically better care. Now, it wasn't a better clinical outcome, it was just dramatically cheaper for the same outcome. And they were voting with their feet, or their hands and their hearts and their heads, more accurately, in terms of how they cared for their patients. And all that I needed to do was make it transparent so they could see how their colleagues were practicing versus how they were practicing. Again, a funny thing about it, this is actually a roll-up slide of about 45 cost items. I never found a single example where one surgeon was consistently good or consistently bad, or one practitioner was. And what it taught you is you really weren't in the business of ranking practitioners. Best care for a patient was scattered across that group. Every one, these were all men as it turned out, every one of these men had a little something to teach and a little something to learn. It wasn't just H who changed his practice, so did M. Now that's a fundamentally different approach, isn't it, where you're focusing on process instead of accusing a person. And as you might expect, it provokes a very different reaction from the people involved in doing the work, and makes a world of difference in your efficacy or efficiency of driving real change. Another example, this was our thoracic surgeons of all people, who would have thought. We were looking at open heart surgery, bypass graft technically. And when a patient left surgery, they went to the thoracic ICU, usually on a ventilator. And they started to flowchart out that process, understand how it worked. When we started, the mean time on a ventilator was 25 hours per patient. And they devised a way to significantly reduce ventilation time. We ran a little trial where it dropped to about 12 hours, about half. The key elements in it were, number one, the medications that the anesthesiologist used during the surgery. Every anesthesiologist was using a different set of medications for heart surgery. And the nurses told us that it made the patients much more difficult to manage when they hit the ICU. Now, they were willing to allow that different patients had different needs, but this was mostly physician-based, not patient-based. And I'm not quite sure how they did it. I wasn't there, but they convinced the anesthesiologist to go to a standard anesthetic regimen for open heart cases, around which the anesthesiologist varied based on patient need. They kind of coordinated it into the ICU, and it was associated with much more rapid recovery times, on average, in the ICU. The second factor, well, it was, in some sense, our night shift nurses. They believed that a healing patient was a sleeping patient. They were a little understaffed on night. They claimed it was all about the patient. We came to believe it was all about the nurses along the way. The physicians were just writing, PRN orders for sedatives. It's really hard to wean a sedated patient from a ventilator, guys. So we standardized out sedation. We started to have routine trials. And those were the two mechanisms that resulted in this drop. Now, we were tracking data with it, but we also had the word of mouth from the nurses themselves. They believed it was just better care. So I've got two classes of data, the measured data and then the qualitative data around experienced clinicians telling you about their practice. And I personally believe that both of those are quite important. Well, it dropped to 10 hours. By the way, when they really tightened it dropped to 4, which was amazing. We actually had some cases where the anesthesiologists, for some good cases, were extubating the patients in the OR. And it was an amazing shift in care. It was associated with some other shifts. This is a length of stay in the TICU. It fell from 2.7 to 1.9 days, directly as a consequence of the change in ventilator weaning practices. Acute care length of stay out in the hospital for after discharge from the TICU fell a little bit. The hospital length of stay fell overall. Now, this was old days, guys. It's not the current standard, in fairness. You're looking at old data, but this was the standard at almost 9 days. And we lost about, 1.2 days, 1.1 days of hospital stay. It freed up capacity to use for other things. In terms of total cost, I had that activity-based costing system. I threw this in. They were also changing their lab testing. Turns out the main lab test they used to affect a wean was an arterial blood gas. At the time, those cost about $40 a pop. And when we went to a standardized way of doing it, we went from 12 ABGs per patient down to 2. So there's a little money in that. We'll sum it all up. Our true cost for doing a bypass graft went from $19,000 to $16,000. And almost all of that, it's a 15% drop in cost of care, is attributable back to weaning practices with a good outcome. So what you're seeing is inefficiency waste. A change in inefficiency waste. By the way, this was $5.5 million per year for the Intermountain system. And it freed resources that we could use for other patients. You kind of see that mechanism. Now, Harry Roberts claimed that this was actually bigger than quality waste, a much bigger category. There is a third category that I need to include. Now, it's interesting in working with Dr. Deming, he never put a name on it. He admitted that it existed, but he would never focus on it. He didn't see it as an opportunity. I would have called it cost effectiveness. The idea is that occasionally you find interventions where the care does improve, right, but the costs go up. You think of it as a cost-benefit curve. So here's a benefit climbing, and usually it tips over, knees out. You get a climb phase, and then it goes flat. Here's the costs going up linearly. And if you look at the gain for each unit of additional cost, you generate this curve down here. And so that's a cost-benefit curve, you see. The fact is some of the interventions we make, you get a better result, but it's a lower cost. The main point for this, it's not a decision that we as clinicians can make. We have to involve those who purchase our services and say, well, if we spend this additional, you'll get this small benefit. Is it worth it to you? Realize that if I spend it on this thing, I won't be able to spend it on that thing. And so we attempt in those circumstances to involve the people who will receive the benefits. David Eddy points out that you need to do that before they're actually at risk. But it's a much harder one. Truth in advertising and my work at Intermountain, I really love it anytime I can go after quality waste or inefficiency waste. It's a no-brainer. There's no conflict. We all win. I hate these. And I will work on one of these when I'm dragged in there kind of kicking and screaming, you see, because it's not black and white like the others are. You're forced into these trade-offs. But I need to include it for completeness. New technology often describes it, defines a whole new level of output, often appropriately costs more, but it's a societal issue. how much you're willing to spend for this little bit of benefit, if you see that idea. Now, if it turns out the new technology costs less, it's almost certainly an inefficiency waste argument, so it doesn't fall into this category. But this is just to summarize. With quality waste, your clinical quality goes up, your costs fall. It's completely an internal decision. We don't have to ask patients not to harm them. They want it every time. Your costs fall. Our best estimates is that it makes up about 25 to 40% of care delivery costs, just in passing. That'd be an argument for another day. Inefficiency waste, there your quality holds flat. Technically, your costs drop. It's entirely internal. You don't have to ask patients about this one either. Harry Roberts, no data. He claimed that it was at least half of any process. It's much more difficult, though, and the reason it's difficult is you don't know you have it until after you've found the new process. So it's experimental. You're doing a series of investigations. This one, if you learn to watch for quality waste, you just look for process failures, and it announces itself. It raises its little hand and says, here, fix me, if you learn to watch for it. If you see that idea. Then cost benefit. Quality is higher, but your costs are higher. It's a societal issue, and it's going to cost you money. It's not going to be better in any way. Now, I just want to show you one last slide. It's in another slide set, so let me just hop over quickly to wrap this up. It's one that I've shown a number of you before, but I think that it's worth reviewing. Let's try again. Some years ago, we've known about this mechanism and been using it inside Intermountain for, well, since about 1987. It's been a long time. Back in 1995-96, I got a mandate from our then CEO to try to take these ideas and build it into a strategic plan. He wanted to make clinical quality our core business strategy. Bill Nelson was our CFO. He's an accountant by training. And it's fair to say that while Bill was very interested in the best possible care of patients, he was interested in the budgets. And he had come to understand that by far the best way to control those budgets was to manage and improve our clinical care. Bill has since retired, but a few years ago, same idea, our current CFO, Bert Zimmerle, showed up. We're mission-driven. We're a community-based health system. We're not for profit. We deliver about 60% of all care in our part of the United States. And Bert made a particular argument. He said, look, if your care is not accessible, quality has no meaning. By definition, inaccessible care is low quality by definition. The way I would translate in this country is it shows up as queues, as waiting lines. It's a way of rationing care, because while some people are on queue, they either opt out of it or some of them die. They disappear, though. It's a way of thinning the herd relative to care delivery services, frankly. Well, he pointed out that, yeah, access is the same as affordable. We had run estimates by which we believed that the total waste burden in healthcare was somewhere north of 50%. Huge waste burden. That came from a little grant I got from AHRQ that Lucy Sabatz and I applied. So we knew that the waste rates were quite high. We had some sense of how you found them and targeted them. And Bert used that relative to our mission. The form that it took, he set a goal for our system. He said, rate increases year over year. He said, I want to hold rate increases that we apply to our patients and those who represent them. For us, that would be insurance companies. In some cases, it's individual patients who are paying for their own care. He said those rate increases should be consumer price index inflation plus 1%. I tried to convince him to say it as gross domestic product minus 2%, which is roughly where it falls. The idea that healthcare begins to cost less and less each year of total gross domestic product. That the burden of healthcare on the community in the face of growing populations, in the face of an aging population, goes down. But that's the goal he set. We build it into a financial plan in terms of where we would need to be financially. Now, this is a growth curve for Utah. It builds in three main aspects. The population of Utah is growing year over year, primarily from in-migration. 30 years ago when I came to Utah, it was about 1.6 million people. Now it's about 2.8. And it looks like the rate of population growth is accelerating. Well, we track that. We use it to plan where we put facilities, where the people are going to be, where the need is. The second big piece is demographic shifts. It's particularly the aging of baby boomers. Of course, as we enter our chronic disease years, our consumption of healthcare resources goes up, so that's built into this line too. And lastly, new technologies. We keep inventing new things that cost more, and so we can build estimates around that too. This turns out to be very conservative. The rest of the United States is growing substantially faster than that. And so we started with a nice conservative growth curve that we thought was reasonable for the state of Utah. And then we said, all right, if we were going to hold our cost to the community to CPI plus 1, where do we need to be? And that's the line we got. This implied that by 2016, when Bert had set this goal to come live, we needed to take $700 million out of our cost of operations. It's about 15% of our total cost of operations. This shows the first 3 years of performance through 2014. Through 2014, now I didn't prepare this. This is a slide from finance, from our finance department, which means the administration actually believes it. If I had prepared it, just as a matter of principle, nobody in the administration would believe it. I should say in passing, but this was prepared by David Dirks, our Assistant Vice President for Finance, and his team. So everybody does believe it, to the point where we take action upon it, financial action upon it. We'd taken out about $440 million. It's about 10%. Now, just in passing, sat yesterday with some of your executives from the Scottish healthcare system, where Tim invited us. It looked to me to pull Lothian back into line, you needed about 1%, was my rough back-of-the-envelope guess. 1%, guys, that's nothing. Well, actually, it is something. But if you look at it the right way, you realize that it's well within your reach. And you get that not by reducing staff, not by increasing queues, not by rationing services, but by systematically improving the quality of care you deliver to your patients. I say this is real. We just committed to other insurance companies and private payers, individual patients in Utah, that for the next 3 years, the way that we're giving that $440 million back is we're limiting our rate increases to about a third of what they would be otherwise, we think. We're going to go with CPI plus 1, but nobody knows what CPI is going to be. And we talked to our major customers, and they said it'd be better just if you gave us a completely predictable rate so we can plan around it, which is very attractive. A lot of those businesses that buy insurance for their people. The state has the Medicaid program for the poor, which is a major state expense. So a government-run system, they really like that idea too. Last year in the US, healthcare costs grew by 5.5%. We guarantee that for the next 3 years, it will grow by 3% or less. Otherwise, we eat the difference. But we've got $440 million to deal with it. That came out of improvement activities. See the idea? This stuff works. Now, the main takeaway is back to Dr. Deming. I sometimes call it Deming's coin. He had the idea that quality and cost are two sides of the same coin, that you really can't talk about one without talking about the other. Said another way, the best way to manage your budgets is to manage your clinical care. The best way to control your budgets is to eliminate waste by improving clinical outcomes. The best way to reduce your costs is by eliminating need through better care to the people who seek your help in their hour of need. We know how to do it. I look at a system like this, you have all the pieces, Tim. You have the leadership, you have the concepts. Your measurement systems could use a little improvement, but that's well within your reach. I think that you're on the verge of a massive breakthrough, a model, not just for Scotland, frankly, not just for the United Kingdom, a model for the world about what's possible. We have not yet begun to understand how good we can be for our patients in our hour of need. And we have a moral obligation to make that affordable so that those who have the need can benefit from our services. Looking ahead. With that, let me stop and say comments, questions, ideas, thoughts. I know that there are 4 or 5 of you who can share your own examples of this. What interests you particularly, or what issues does this raise? I think that they have a microphone for you. Oh, here they are. So, thank you.
So, you raise a lot of interesting points. Over the years, I've heard many similar discussions amongst colleagues. But one of the problems that we haven't learned to manage is the outside regulation of our services.
Yeah.
So if you took away a group of us, our cardiac surgeons, for example, they do more operations than they used to do. They do them now, and people, my God, when I started, didn't even get into hospital.
Yeah.
And these people survive and they have terrific outcomes.
Yeah.
The cardiac surgery is that little bit of medicine.
Yeah.
Well, it isn't medicine. It's that little bit of activity where there isn't much regulation. It's very outcome driven.
Yeah.
And it's a small part of our work.
Yeah.
But they've made fantastic improvements, short length of stay. And then you come to the big dinosaur, cardiology, guidelines, new treatments you mentioned there.
Yeah.
People are now proposing that we prescribe a drug that will cost us £1 million for a 1% benefit.
Yeah.
Throw away an old drug that served us well for 10 years.
Yeah.
And this is outside regulation forcing the change on us.
An idea. Yeah, I understand that these things happen. They happen to us too. You've hit 2 of my favorite soapboxes, and these are particularly tall, and I have a tendency to step up on top of them and rail, to no effect, by the way, but government regulation, and then I think that the pharmaceutical industry, I think they're raping us a little bit, taking advantage of our good work to line their pockets, but I'm sure they see it differently. What can you say? You raised the issue of cardiology, but another little story, a real one. Started in 2013. We have a program to manage cardiovascular medicine. It's led by a cardiologist named Don LePay. He has a full-time nurse assistant, Colleen Roberts. Frontline clinical knowledge, they're in active practice, are deeply respected by their peers. With apologies to those of you who've already heard this story, it's a quite telling one, and I think it fits exactly. Well, Don knows a little fact. It comes out of our quality training. David Eddy's the man who said it. Now, David Eddy's the first person to use the phrase evidence-based medicine in the published literature in 1990 at Stanford University. He developed most of the formal methods we use for evidence-based reviews, too. He preceded Sackett by about 5 years, just in passing. The way Eddy says it is, with strong evidence, is the complexity of modern medicine exceeds the capacity of the unaided human mind. And that's demonstrably true. I don't care how specialized you are. It shows up as an inability to execute. So Beth McGlynn's work, for things where we have hard evidence of benefit, we know it works, they tend to be non-controversial. We all agree it should happen. She showed that for adults, we managed to get it right about 55% of the time, for children, 46% of the time. And then she raised a really interesting question. She says, you know, you rightly argue that we fairly routinely achieve miracles. We have all this benefit from clinical practice. If you can get miracles doing it right about half the time, what kind of miracles could you get if you did it right somewhere closer to 100% of the time? And it's a legitimate argument, right? But it has to do with complexity. The reason it fails is the model for care delivery we use. That model is based around the idea of what's called the craft of medicine. Craft of medicine, every physician, every nurse is a master craftsman. We start with a fundamental ethical commitment to put patients first. We add on top of that this massive knowledge base gained through formal education and from treatment experience. And the idea is we take patients one at a time. That's why we call it a cottage industry, one at a time, and starting largely with raw materials, one patient at a time, we create a unique diagnostic and therapeutic experience customized to that individual. And the promise we make as a profession is that this guarantees best possible medical outcome. Now, you need to know that that viewpoint does not withstand scientific scrutiny at all. The ground shifted under our feet in the last 100 years. It was a great idea when it was first applied, it worked, but it was a complexity problem coming up. It got to be too complex. Well, Don knew that. What he had was some expert cardiologists, widely respected at a national level. Major researchers, Jeff Anderson, Brent James, a very, very well-respected group. But in choosing when to do cardiac procedures, he realized that they were doing it with a Kraft model based upon their expertise, and he knew that that didn't work. What he did was take the American College of Cardiology guidelines for appropriateness for cardiac cath, stenting, electrophysiology, implantable pacemakers, and defibrillators, all right? He managed to fit them on one side of one sheet of paper with reasonably large printing. It was really a series of little check boxes, and he just went to his colleagues and said, look, when you're going to do one of these things, would you please just check off the indications? We had a pragmatic argument. A lot of insurers in the United States trying to control utilization rates, they have this thing called pre-authorization, and it can be extremely painful. It's a Mother May I system where before you do the procedure, before they'll pay for it, you have to call them up and get permission. They very often will ping you for additional data. Very often the physician has to get on and argue with them. We said, well, we've worked it out with the insurers that if you just check off the indications, you've got automatic pre-auth. And that was very attractive. Now, when they started, we were among the best in the country in terms of utilization rates for cardiac procedures. We were in the bottom quartile of the United States in use rates on a risk-adjusted population basis. They deployed this thing, and we watched our use rates fall by about 25%, just under 25%. It was sobering. These were some awfully good clinicians. They were careful, thoughtful people, and you realized that a quarter of the cases that we're treating almost were clinically inappropriate, where the risk of the treatment outweighed any potential benefit to the patient. They should not have been done. Now, interestingly, the way those cardiologists responded to that, some of them took a cut in income too. It was a funny combination of humility and pride. They understood that their colleagues across the United States were still abusing this terribly, not purposefully, but they took real pride in knowing that they were doing the right thing to the right patient with measured benefits. That one, the first year we deployed it, saved $13 million in cost of operations. The following year, 2014, that was $30 million of the savings, that one. And believe it or not, that pays for a fair bit of drugs. Is one of the ways that we think about it, you see. Now, I still don't like the fact the pharmaceutical industry is raping us. One of the things I would be doing for that, which we do for it, is that we put in very clear appropriate use criteria. It's not based on qualities particularly. I heard an argument yesterday from your executives that they said, go drugs up to, they were complaining that they were up to about $75,000 per quality adjusted life year. I have to tell you, in the United States, the cut point's more like 200,000, just in passing. But we do it just on the basis of patient benefit. And what I believe is when you get those levels of waste and you start to pull out the waste, so far I can stand the sloppiness. I can live with the silly regulation we get down from on top. I can live with, I've got to figure out a way to deal with them, but I can live with being abused by the pharmaceuticals and still deliver good care to my patients. You see what I mean? And at least I realize that's not a good answer, but so far that's how we're thinking about it. Through excellence, we're carving out enough of a space that we can deal with the crap. We need to fix the crap, and I agree with you entirely. But I'm going to stay away from that soapbox. I've taken too long already. Other comments or questions? Other thoughts? Yes, sir. And right here next, okay?
Andrew Morris, you've touched upon measurement as being key. From what
Yes.
you've seen over the last 72 hours, could you compare and contrast our approach to measurement to yours?
Yeah, there are two things that really struck me about your measurement approach. You use the word performance differently than I do. For you, performance is top-down regulatory compliance. So you have a fairly high degree of government demanding measures. What I know is, it appears to be the same for you as it is for me. Most of those measures are not helpful in improving clinical practice. They're produced for a different purpose or not helpful. That's what I mean when I say regulatory waste. And it's very annoying. It consumes resources that I would much rather apply to better care. And of course, the people who are doing it assumes that it somehow produces better care. They need to follow through on their change models. I think it's very short-sighted. And it comes from a very low level of understanding about how things really work down at the front line. And their lack of knowledge, their lack of expertise, their lack of ability is no excuse for doing it to the rest of us, if that's fair. All right? So, guys, I hate, here goes that soapbox. You can see it's there, and you get me going, and I can hold forth for a half hour like that, and even you'll get tired of it. But yeah, we're still forced to comply just as you are. The other thing that I've noticed, when I think about quality, what it means to me is process management exactly. And process management means I have to have defined processes of care, and then around them I have to build a data system. And the primary purpose of that data system for me is performance, not as measured by somebody outside, but as measured by us, performance on behalf of our patients. It's a management system. It actually resonates fairly well for our financial people because it looks like the kind of management systems they try to use for finances, you see? But this one's clinical. Oh, the next thing, when I'm running a clinical management system, I'm of course tracking intermediate and final clinical outcomes, critical. I also track cost outcomes in parallel because of this, Deming's relationship of quality and cost. And I'm always looking at the clinical and then how it interacts with the cost, because remember, if it's not accessible, it cannot be high quality. And I think that's a legitimate argument. So I build that transparency in too, side by side. You know, this is an inexhaustible well of opportunity sitting here is what I believe. So there would be others. You'd have to find them. But the first key to it is, how do I make it transparent so the physicians and nurses, the administrators involved, can see clearly what's happening? And then in that structure, I start to launch improvement activities. Now, the next thing that will happen with that is you'll build a learning healthcare system. Last year, in our community-based care delivery system, we published about 200 peer-reviewed articles. That's in those relatively rare instances where somebody got excited and decided to take their improvement project and get it into a publication format. It's extra work. We're probably not going to pay you to do it, by the way. You're going to do that on your own time, but they get excited about it and go do it, which is really neat for building reputation. My goal is before I quit, well, I'm trying to get administration to fund that activity, because I argue that we really ought to, that it fits in. I'm going to win that one, I think, coming up here. And I would like to see us publish 1,000 articles in peer-reviewed journals in a single year. I have a really fun time at the universities where I work, by the way. I tease them. I say, number one, we know how to manage care, guys, manage clinical outcomes. We're delivering better clinical outcomes than you. We're going to steal all of your patients. Frankly, I don't know if we should allow patients to go to a typical university. I know that you claim to be clinical scientists, but you're not behaving like scientists in terms of your clinical performance. You have the tools of measurement that you use when you're doing research. Well, what if we just shifted those over and focused them on care delivery performance? You're going to get some real shocks, guys. But I think with a higher quality outcome and lower cost of care, I can steal all your patients. By the way, I don't believe that'll actually happen. I'm just trying to provoke them. They should be doing this. They've got all the skills and talents. They should. And then just to follow on to it, I said, by the way, I'm going to take away all of your T4, T5 clinical research. Because if I build that learning healthcare system, my ability to do what's called translational clinical research goes up dramatically. My expense for doing it drops as dramatically. I link it into routine operations, right? You can keep the lab stuff with government funding, but the rest of it, you know, if you want to be an excellent doctor delivering good care and you want to do translational research, you ought to come over with us. So this is designed to be provocative, and as you might imagine, it is. And never miss a chance, right? You are next.
Thank you very much. It just occurred to me that there was another nice synergy, and I'm sure you've thought of this already, that as you increase quality and reduce cost, a lot of the treatments seem to me more humane, and it's much nicer to have a shot of antibiotic than a deep tissue infection.
Yeah.
It must be hugely better emotionally as well as physically to be on ITU for 4 hours instead of 24. And going back to your first example about the person with alcohol dependence on ITU,
Yeah.
and this is coming to my question, I guess, is a lot of the change you've talked about is within institutions. The alcoholic man, I would say the answer to that is in primary care, where we can manage his alcohol and help him and his family approach a palliative understanding of his condition, so that he doesn't go to ITU. And some of your parallel processes,
Right.
we're beginning to look at. There are cheaper, higher quality options with especially the frail elderly and keeping people at home. So I just wondered if you had a concept about primary secondary care, if you have that divide, and also how you change things where you need a change between systems or institutions and not just within them.
I can't find a particular slide. We actually think of, well, background. I'm a member of the National Academy of Sciences in the United States, and I serve on something called the Committee on Quality of Healthcare in America. We published 2 reports. The first was To Err is Human, about patient safety, that really kicked off the whole patient safety effort worldwide. There was also some really good efforts happening, particularly in Australia, a little bit in Canada with Peter Norton, but we kicked off that. The second was called Crossing the Quality Chasm, which was our prescription for reform of modern Western-style healthcare systems, still very topical today. I think it's one of the final works with which I've ever been associated. Within it, we defined a term, the first use, I think, that was ever made of the term patient-centered care. That term arose with Don Berwick, who was on the committee. But here's precisely what we meant. Most of what we do in care delivery is actually disease treatment. And we have a concept called continuum of care that starts up in a population level before a disease ever manifests. You try to prevent, right? You screen, detect, identify. You begin minor treatment. Sometimes it escalates over time, but hopefully to some sort of a reasonable resolution. That continuum spans all the way from population level down to end of life, you see? And our concept of patient-centered care is, what if we organized care around the patient? Now that stood in contrast to other ways of organizing care. The most common by far is you organize around physicians. Or you organize around a piece of technology like a scanner or a surgical robot. Or you organize around a building like a hospital or a clinic. What if you organized around a patient? Now, another name for a continuum is a process of care. And so when I say a process-based management system, that's what I mean. Lately, we are moving more and more of Intermountain's care into budgeted care, what we would call capitated care, where we bear full financial risk and are given a budget per risk-adjusted per person per month, typically, to provide all of their services. And when you're in that setting, you have very strong incentives to do something called move upstream, you see, within that particular setting. And we've been finding lots of ways to move upstream. Our whole aim is to keep patients out of our hospitals. That's a big part of the waste that I've been talking about, is move upstream strategies. We sometimes call it hot spotting, is what we call it. And we find lots of different ways to do it, and we take those actions. The truth is that we're a disease treatment system mostly, so very often for the high order stuff, which is up at the level of social networks, physical environment, public health, very often we find that we're a convener, a collaborator, an instigator, pulling together local schools, religious organizations, local governments to try to fundamentally change the physical, social, public health environment so that people don't need our services. And we've had some real successes. If I had the slide, I'd show you the general model. Turns out it has real high leverage. We realize that we're not the right group to do most of it. We think that when we save money, as I've described, that what we're doing, we had a big debate about this, by the way, should we take the money we were saving and use it to put people in housing? And we eventually decided that no, we're a care delivery system. That responsibility, that obligation really belongs to others. So we shouldn't be stepping into their role. We should be helping them fulfill their own role in a coordinated way. So we see ourselves as a convener, right? An instigator. And I think that's the right decision. We could debate it endlessly, by the way. It means you give the money back to the community. back to government, for example, and then ask them how to use it. This is really dicey because I'm not sure I want to give money back to those people. I know that you wouldn't want to. But by the way, that's one of the reasons that you're appropriately in this role.
All right, okay.
So.
Well, I'm sure we could go on for a lot longer, but we did say that we would draw stumps at about 7, and I have to confess something to you, Brent. At birthday time and Christmas time, members of my very close family often say to me, "Thanks so much for your gift. It was really thoughtful of you." And I say, "What did we get you?" Because I probably wouldn't even know it was their birthday.
Please don't talk
and so I actually know what we're giving you, though, because I've just looked at it. And it was probably more thoughtful of Dr. Edgar than of me, but it is a book of beautiful photographs of the Scottish Highlands, and I hope that you'll accept that as a little token of our appreciation.
Thank you very much. I had fun bringing my wife and 2 young daughters with me, and it turned out with their school started, and it didn't work out, and so this is second best to having here. This is very, very nice. We greatly appreciate it. Thank you.
Thank you very much. So just to close up, I was saying yesterday at a management team meeting that Brent was talking at, I was quoting my favourite Bob Dylan, and there was a great line from a song called Simple Twist of Fate, which has a little verse in it which says, "And when finally the bottom fell out, I became withdrawn. The only thing I knew how to do was keep on keeping on." And I put out the question, what was the next line? And one of our anaesthetists said,
I'm going to shout it out again.
Where are you? Where are you? Right, so, okay, so, and when finally the bottom fell out, I became withdrawn. The only thing I knew how to do was keep on keeping on.
Someone else. Like a bird that flew.
Tangled up in blue. So anyway, I think the point of that, was that I have come to the conclusion that we cannot just keep on keeping on, that we are heading for a cliff and we're going to fall off the end of it. And so in those circumstances, as the leader of this organisation, I need to set a new direction. Now, the new direction has to be based, I think, on some of these principles that Brent has been talking to us about for the next few days. It is very much about putting quality at the heart of what we do. It is about using data to be clear about how we are performing against optimal processes of care, measure variation, and also to measure improvement against it. And so we are developing in the management team and with the board and with our Edinburgh and Lothian Health Foundation, which is hopefully going to support us with some investment, and with the government, which we I think are confident will also support us. We are going to create a vehicle which will drive this new approach to quality, and that vehicle will be the NHS Lothian Quality Academy. We haven't got a business case yet approved, but we are developing one, and I'm confident that we will get this off the ground. The academy will be brought into life by what we call the faculty, and the faculty will be the staff who will drive the training on some of this improvement methodology, will support, coach, mentor, support with analytics and data management, will support with financial information, with information systems, will support with improvement methodology, skills and capacity. We'll have a faculty, and that faculty will include a lot of people that we already have, but we're going to marshal them in a much more focused way. There are IHI improvement advisors, our SPSP fellows, our efficiency and productivity program managers and modernization team managers who've all been lean trained, our data analytics staff, our finance team and our e-health team, and we're going to choose some high cost, high intensity clinical processes in Lothian. So that might be outpatient chemotherapy, it might be laparoscopic prostatectomy, it might be fractured neck of femur, it might be implantable cardiac devices, it might be psychological therapies. We have to start somewhere, and we're going to identify some areas, we're going to engage with those clinical teams at the level of the micro system, not at the level of NHS Lothian, but at the level of the urology team at the Western, or the psychological therapies in South East Edinburgh, or the orthopods at the Royal Infirmary, or whatever it might be. And of course, it's all about, just looking at Katrina, burning eyes into me. It's not just about acute it's all about the pathway as well as the process of care. And so we are developing a business case, and that faculty that I'm talking about that might have maybe 40 or 50 people in it initially has just been extended. I just got an email earlier saying that we had 5 clinicians in Lothian who this year applied for the Safety and Quality Fellowship, and all 5 were shortlisted in a very competitive process, and all 5 have been appointed to undertake the fellowship this year. And those 5 clinicians will augment our faculty of improvement support that will begin to work with some of our clinical teams around these high-cost, high-interventions. And just to name-check them, I don't know whether any of you are in the audience. Richard O'Brien, MOE stroke. Rachel Hignett, maternity anaesthetist. Andy Tambaraja, vascular surgeon. Jane Cheeseman, psychiatrist. Lisa Carter, Lothian Unscheduled Care Service. So well done. We will take, I think, Brent's challenge, which is, to be fair, Brian Houston's challenge, our chairman, who has done a lot of this stuff in other industries. That you always go home at night feeling uncomfortable that we're going to drown financially for the sake of 1 or 2%. You know, and I can't believe that we're going to allow ourselves to drown for the sake of 1 or 2%. I believe we have at least 1 or 2% worth of waste or inefficiency or unnecessary care or treatment, and we're going to go after it. And we can't start everywhere, we have to start somewhere, but we're going to go after it systematically. We're going after it with a proven methodology. We're going to go after it with staff who have a burning desire to do what we want to do, which is what is our aim. So the triple aim, the IHI triple aim. So it is to protect and improve the health of the population. It is to improve the quality and safety of our healthcare, and it is actually to improve value for money and financial sustainability. So all of these things, as Brent, I think, has taught us so well today and throughout the whole of this week, actually. So we're going to go after it. We will have another clinical change forum in a couple of months. I'm looking at Alex, whether you know the date.
September.
30th of September. It's on our website, it's on our intranet, and we hope that we see another full house to hear more detail of what we've done and the areas that we're going to choose. And actually, we're just going to get started. And hopefully we'll have a few graphs of our own to share with you in the months ahead. So, thank you very much for coming. Thank you again to our speaker, Brent James, and safe journey